Hematological malignancies. Leukemia. Most common hematological malignancy is leukemia. Characteristic feature clonal, clonal proliferation plus arrest of maturation. Tumor cells composed of immature cell series. Tumor cells composed of immature cell series. Types of leukemia. Most common acute lymphoblastic leukemia is more common than acute myeloblastic leukemia. Acute lymphoblastic leukemia incidence most common malignancy in children, age group 2 to 5 years. Gender males more common than females. Conditions with increased risk of ALL is ataxia, telangiectasia, Bloom's syndrome, severe combined immunodeficiency, SCID, Down's syndrome, environmental factor, for example, ionizing radiation, Fanconi's anemia, Lefromanni syndrome. Classification of acute lymphoblastic anemia. Immunophenotypic classification based on cell type. Pre-B cell, CD markers via flow cytometry and management. Pre-B cells, most common 85%. Mature B cells, second most common, and T cells. Pre-B cells, most common 85%. CD10 markers and good prognosis. CD10 is a marker and good prognosis. CD10 marker. CD19, CD20 and CD45 are also markers for pre-B cell, which is most common 85%, good prognosis with treatment. Then comes mature B cell, second most common. Again same, CD19 and CD20 is common, and then comes CD21. Serum immunoglobulin positive, surface immunoglobulin positivity, CD19, 20, 21, easy to remember for mature B cells. So management intensified treatment is required. And then comes T cells. In that CD2, CD3, 4, 5, 7 and 8. So it is 2 to 8 without 6. Mediastinal involvement noted and plus CNS manifestation. Mediastinal involvement is noted and there is CNS manifestation. Cytogenetic classification based on chromosome number and translocation. Cytogenetic classification based on chromosome number and translocation. General features: bone marrow failure, pancytopenia, causes anemia, thrombocytopenia present as petechiae, and leukopenia. General features: bone marrow failure, pancytopenia, presence as anemia, thrombocytopenia and leukopenia. Exception: leukocytes may be seen in few patients. Night bone pains due to infiltration. Extramedullary involvement: more than 60% cases have extramedullary involvement. Infiltration of liver and spleen, hepatosplenomegaly and splenomegaly. Infiltration of liver and spleen, hepatosplenomegaly or splenomegaly. Superficial lymphadenopathy, non-tender, firm, fixed, confluent. Superficial lymphadenopathy, non-tender, firm, fixed and confluent. Mediastinal involvement, tracheal compression, unexplained cough and breathing difficulty. SVC syndrome, compression of superior vena cava, decreased venous stasis, facial flushing, edema, jugular vein distension. Superior vena cava syndrome, compression of superior vena cava, decreased venous stasis, facial flushing, edema and jugular vein distension. That is the SVC venous syndrome, facial flooding, edema and jugular vein distension. CNS leukemia, cranial neuropathies, seizures, increased intracranial tension features, and 5. Testicular leukemia, painless unilateral bilateral testicular swelling, but it is painless. Diagnosis: bone marrow aspiration and biopsy. Aspiration may be normal, more than 25% lymphoblast. If present, is a diagnostic of acute lymphocytic leukemia. So what is the diagnosis for leukemia? Acute lymphoblastic leukemia is bone marrow aspiration and biopsy. Bone marrow biopsy can be normal. If more than 25% lymphoblasts are present, then it's diagnostic of acute lymphocytic leukemia. Classification based on prognosis. Classification based on prognosis. Standard risk, good prognosis. High risk, poor prognosis. It's divided as that. So what are the good prognosis and or standard risk? So child in between 2 to 10 years of age, female, no CNS development, initial white blood count is less than 50,000 per meter cube, initial white blood count is less than 50,000 per meter cube, subtype is pre-B cell, cytogenetics to determine prognosis is hyperdiploidy, more than 50 chromosomes, and trisomy 4 and 10. Hyperdiploidy, more than 50 chromosomes, and trisomy 4 or 10. So standard risk or good prognosis is as follows. The child is between 2 to 10 years of age. The child is a female. There is no CNS development. When the leukemia is detected, then the WBC is less than 50,000 per meter cube, because the leukemia is increase in white blood cells. So it's still less than 50,000, so that is a good prognosis. And then it is subtype is pre-beta cell, like we read here. The marker of pre-beta cell, most common 85%, is CD10. So that is also a good prognosis. And then cytogenetics to determine prognosis, hyperdiploidy, more than 50 chromosomes, and trisomy 4 and 10. That if you find in cytogenetics is a good prognosis. Now high risk and poor prognosis. If you find the tumor in less than 1 year old or more than 10 years, then it is a bad prognosis. Males, CNS development present, CNS involvement present, WBCs already reach more than 50,000. Subtypes B cell and T cell. Cytogenetics, hypoploidy, 44 chromosomes. Translocation, T922, Philadelphia chromosome. T922, Philadelphia chromosome. T411, infantile leukemia, less than 1 year old. T411, infantile leukemia, less than 1 year old, has T411. So what are the bad prognosis of leukemia? That it is diagnosed in less than 1 year old or more than 10 years old. It is a male child. There is a CNS involvement. WPCs have already reached more than 50,000. And then the subtype is B type or B cell type or T cell type. And when you do cytogenetics, then you find hypoploidy, that is 44 chromosomes, and translocation T922, which is also known as T922 is known as Philadelphia chromosome, or T411 translocation, which is found in infantile leukemia, less than 1 year of age. Treatment is in phase 1, 2, 3, 4. Goal and medications. Treatment, phase 1, 2, 3 and 4, goal and medications. So phase 1 is induction phase. Phase 2 is prophylactic CNS therapy. Phase 3 is consolidation intensification phase. Phase 4 is maintenance phase, once a week for 2 years. Phase 4 is a maintenance phase, once a week for 2 years. So phase 1 is induction phase of the treatment. Goal to induce remission, look for response. Goal is to induce remission and look for response. So a good response, good prognosis, that is reduce in WBC count, no blast cells in bone marrow and circulation. Minimal residual disease, MRD, cannot be detected by conventional methods. Test is flow cytometry or PCR. No minimal residual disease, then it's a good prognosis. Medications, you see prednisolone, L-asparaginase, anthracycline, and vincristine. Which medications? Induction phase, which medications to use? Prednisolone, L-asparaginase, anthracycline, and vincristine. So phase 1 is induction phase. Goal is to induce remission and look for response. Good response means good prognosis. How do you see it's a good response? There is a reduce in WBC count, there is no blast cells in the bone marrow and circulation. What is minimal residual disease? Minimum residual disease is that it cannot be detected by conventional method, but it is detected by flow cytometry or PCR. If there is no minimal residual disease, then it is a good prognosis. Which are the medications which are used in the induction phase, phase 1? It's prednisolone, L-asparaginase, anthracycline, and vincristine. Type 2 prophylactic CNS therapy. Type 2 is prophylactic CNS therapy. That's type 2. Type 2 is prophylactic CNS therapy to treat subclinical CNS involvement. It is to treat subclinical CNS involvement. What is type 2? It is prophylactic CNS therapy. It is used to treat subclinical CNS involvement. So when there is no symptoms but subclinical, then it's phase 2 prophylactic CNS therapy. And in this you give intrathecal methotrexate. In phase 2. Consolidation phase 3, intensification phase, tackle drug resistance and sustain remission. So sustain the remission that is achieved and tackle drug resistance. Which drug are you using in it? You are repeating methotrexate and then epidophylotoxin, cyclophosphamide, and cytosine arabinoside. So methotrexate, epidophylotoxin, cyclophosphamide, and cytosine arabinoside. These are the intensification phase 3 medications. Maintenance phase, once a week for 2 years. Maintenance phase is once a week for 2 years. So once every week for the coming 2 years, that is your maintenance phase, to prevent any relapse. So there is no relapse. So medication is 6 mercaptopurine and methotrexate. So you have seen that methotrexate is in phase 2, 3 and 4. AML, acute myeloid leukemia, second most type of leukemia. Classification, FAB classification. So FAB classification is M0 to M7, M0, M1, M2, M3, M4, M5, M6, M7. M0 is minimal differentiation, M1 is without maturation, M2 is with maturation, M3 is APML, acute promyelocytic leukemia. Acute promyelocytic leukemia is APML, acute promyelocytic leukemia. M4 is myelomonocytic leukemia, M5 is monocytic leukemia, M6 is erythroleukemia, and M7 is megakaryoblast leukemia. So M0 to M7. M0 minimal differentiation, M1 without maturation, M2 with maturation, M3 APML, acute promyelocytic leukemia, M4 myelomonocytic leukemia, M5 monocytic leukemia, M6 erythroleukemia, M7 megakaryoblast leukemia. Genetics and response to therapy. Genetics, favorable risk factor and high risk factor. So favorable risk factor for genetics is inversion 16, T821, CEBPA gene mutation codes for transcription factor for maturation of myeloid cells, NPMI gene mutation, inversion 16, T821, CEBPA gene mutation codes for transcription factor for maturation of myeloid cell, NPM1 gene mutation. These are favorable risk factors and they respond to chemotherapy. High risk factor is monosomy 5:7 and 5q deletion. What is high risk factors? Monosomy 5:7 and 5q deletion. Response to hematopoietic stem cell transplantation. It responds to hematopoietic stem cell transplantation. Clinical features. Clinical features of acute myeloid leukemia is similar to acute lymphoid leukemia. Exception, hepatosplenomegaly is rarely seen, is present in M4 and M5 variety, and there is low lymphadenopathy. What is M4 and M5 variety? It is myelomonocytic leukemia and monocytic leukemia. So it is similar to acute lymphoblastic leukemia, but hepatosplenomegaly is rarely seen. There is no lymphadenopathy. very high WBC counts, leukostasis, lung infiltrates, and stroke manifestations. The WBC count is very high. WBC count in acute myeloid leukemia is very high. There could be lung infiltration, there could be stroke manifestations, disseminated intravascular coagulation in M3 varieties. So M3 varieties, which is APML, acute promyelocytic leukemia. You have DIC varieties, disseminated intravascular coagulation in APML, acute promyelocytic leukemia, which is the M3 stage of acute myeloid leukemia. Gum hypertrophy seen in M4 subtype. We just saw that it is monocytic myelomonocytic leukemia, that is M4. M4 is myelomonocytic leukemia. So you see gum hypertrophy in M4 type. Chloroma myeloid sarcoma, deposition of leukemia cells in skin due to extramedullary hematopoiesis. That is called chloroma or myeloid sarcoma. Chloroma or myeloid sarcoma. Chloroma or myeloid sarcoma Chloroma myeloid sarcoma, deposition of leukemia cells in skin due to extramedullary hematopoiesis. Bone marrow aspiration is more than 20% myeloblast. In bone marrow aspiration, you will see more than 20% myeloblasts. So diagnosis is again bone marrow aspiration. In acute lymphoid leukemia, you see that bone marrow aspiration more than 25% lymphoblast. But here you will see more than 20% myeloblast. Treatment induction phase is done by cytosine, arabinoside, and duonorubicin, and consolidation phase, cytosine, arabinoside, and etoposide. So first induction phase you get by cytosine, arabinoside, and duonorubicin, and consolidation phase you get by cytosine, arabinoside, and etoposide. Drug used in M3 phase. M3 phase is APML, that is acute promyelocytic stage, right? Acute promyelocytic leukemia. ATRA, all trans retinoic acid, tretinoin. ETRA, all trans drugs. What are the drugs used in M3? That is acute promyelocytic myeloid leukemia. ETRA. What is full form of ETRA? All trans retinoic acid or tretinoin. All trans retinoic acid or tretinoin. What it causes? Differentiation of malignant cell to mature cell. Differentiation of malignant cell to mature cell. That is used in M3. Coming to lymphoma. Types divided 40% and 60%. 40% is Reed-Sternberg cell, RS cell positive, and 60% is RS cell absent. So RS cell positive, that is Reed-Sternberg cell. Reed-Sternberg cell positive is Hodgkin's lymphoma or Hodgkin's disease. Hodgkin's lymphoma or Hodgkin's disease. Reed-Sternberg cell absent is non-Hodgkin's lymphoma. 60%. Reed-Sternberg cell absent is non-Hodgkin's lymphoma, NHL. Hodgkin's lymphoma, HL. Age group 15 to 19 years of age. Hodgkin's lymphoma, age group 15 to 19 years of age. Gender, male predominance. It has a male predominance. Hodgkin's lymphoma, age 15 to 19 years of age, and gender, it has a male predominance. Risk factor: infections, HHV6 CMV Epstein-Barr virus increase risk by 4x. Autoimmune disorders like SLE. Risk factors of lymphoma infections. Hodgkin's lymphoma and that infections like her HHV 6. CMV cytomegalovirus Epstein-Barr virus increase risk by 4x. Autoimmune disease like SLE. Autoimmune diseases like SLE. Systemic lupus erythematosus. Clinical features. Most common clinical features is lymphadenopathy. Most common is cervical. Most common clinical feature is lymphadenopathy. Most common cervical. Painless, matted, firm, rubbery consistency. Most common clinical feature is lymphadenopathy, cervical. We are talking about lymphoma. It is painless, matted, firm, rubbery consistency. Constitutional symptoms. What are the constitutional symptoms of lymphoma? There is a high-grade fever, 38 degrees Celsius, drenching night sweats, weight loss more than 10% from last 6 months. If these symptoms are absent, grade A, good prognosis. If these are present, then grade B, poor prognosis. So cervical lymphadenopathy is the most common clinical symptom, where the lymph nodes are painless, matted, firm, rubbery consistency, and it comes with constitutional symptoms like high grade fever more than 38 degrees Celsius, drenching night sweats, weight loss more than 10% in the last 6 months. If these are absent, then it is a good prognosis. If these are present, then it's a bad prognosis. Types. Positive CD markers of lymphoma. Classical is CD15 and CD30. What are the classical CD markers of lymphoma? It is CD15 and CD30. CD15 and CD30 classical. Rein-Sternberg cell on excisional biopsy of lymph node, malignant transformation of germinal B cell, owl eye inclusion body. Owl eye inclusion body is, if Rein-Sternberg cell is present, then it is a Hodgkin's lymphoma. Markers are CD15 and CD30. Non-lymphocytic predominant, nodular lymphocyte predominant, CD20 and CD45. Here we are talking about Hodgkin's lymphoma, that is Reed-Sternberg cell positive. So this is a classical type, and then we have the nodular lymphocyte predominant. In that the marker is CD20 and or 45. It's almost double. Classical is CD15 and 30, and here it is CD20, and instead of 40 it is just 45. That is the nodular lymphocyte predominant, and it has the popcorn cell on peripheral smear. Subtypes of classical Hodgkin's lymphoma. So you have subtypes. 4 subtypes are mentioned: nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. What are the 4 subtypes of classical Hodgkin's lymphoma? Nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. Most common worldwide is nodular sclerosis, and females more common than males. Mixed cellularity is most common in India, and males is more common than female. Reed-Sternberg cell variant, nodular sclerosis is lacunar. Epstein-Barr association is not present with nodular sclerosis. Prognosis is excellent. Mixed cellularity, which is most common in India and is present more in males than females. In that, Epstein-Barr virus association is present, and it has a good prognosis. Lymphocyte rich and lymphocyte depleted. Classical Hodgkin's lymphoma. Lymphocyte rich has Reed-Sternberg cell variant mononuclear, and lymphocyte depleted has Reed-Sternberg cell variant reticular. They are also associated with Epstein-Barr virus. Lymphocyte rich has excellent prognosis, but lymphocyte depleted has poor prognosis. So the only variant of non-Hodgkin's classical lymphoma that is not associated with Epstein-Barr virus is nodular sclerosis, which is most common worldwide. Poor prognosis is lymphocyte depleted. Treatment based on modified Ann Arbor staging. What the treatment of Hodgkin's lymphoma is dependent on Ann Arbor staging. The treatment of non-Hodgkin's lymphoma is based on modified Ann Arbor staging. So there are 4 stages: stage 1, 2, 3, and 4. Stage 1, you have single lymph node. Stage 2, more than 2 lymph nodes affected on one side of the diaphragm. Stage 3, multiple lymph nodes affected above and below the diaphragm. Stage 4, multiple lymph nodes and organs affected. Multiple lymph nodes and organ affected. So what are the stages of non-Hodgkin's lymphoma? Classical. It is the treatment is based on modified Ann Arbor staging, which is like that: single lymph node stage 1, 2 lymph node, all lymph nodes above the diaphragm stage 2, above and below the diaphragm stage 3, above and below the diaphragm plus organ involvement stage 4. When Reed-Sternburn cells are not present, it is called non-Hodgkin's lymphoma, and when it's present, then it's called Hodgkin's lymphoma. So we are talking about Hodgkin's lymphoma right now. So 1, 2, 3, 4. The treatment options: clinical presentation until 3A is favorable, after 3B is unfavorable, and in any cancer staging the stage 3 is important. So until 3A of Hodgkin's lymphoma it's a favorable, after that it's not favorable. 3A after and what is the treatment? Chemotherapy, ABVD. The acronym is ABVD for treatment of Hodgkin's lymphoma up till 3A, which is ABVD: A for adriamycin, B for bleomycin, V for vinblastine, and D for dacarbazine. A for adriamycin, B for bleomycin, V for vinblastine, and D for dacarbazine. Adriamycin, bleomycin, vinblastine, and dacarbazine. And after 3B onwards it is unfavorable, and treatment is chemotherapy, radiotherapy, involved field radiation therapy. Any stage with X and E. X is bulky, more than 10 centimeter size, and E is extension into extra lymphatic site. So any stage with X is bulky, that is more than 10 centimeter lymph nodes, and E is extension into extra lymphatic sites, is also unfavorable. Non-Hodgkin's lymphoma, age group 5 to 15 years. Non-Hodgkin's lymphoma, age group 5 to 15 years. Types of non-Hodgkin's lymphoma based on lymphocyte of origin: B cell type, T cell type, and intermediate cell. Based on lymphocyte of origin: B cell type, T cell type, and intermediate cell, B cell type. So when it is called non-Hodgkin's lymphoma, when you do not have the Reed-Sternberg cells present in the biopsy. So we are dividing the non-Hodgkin's lymphoma in the type of origin of the lymphocyte. So it is B cell type, T cell type, and intermediate cell. B cell type is Burkitt's lymphoma, which is the most common worldwide, and diffuse large B lymphoma. What are the two B cell type? Is Burkitt's lymphoma, which is most common worldwide, and diffuse large B cell lymphoma. T cell type is most common in India, is lymphoblastic lymphoma. What is the most common T cell lymphoma in India? Lymphoblastic lymphoma. And anaplastic large cell lymphoma. Clinical features: B cell types, Burkitt's lymphoma. Clinical feature: B cell type, Burkitt's lymphoma. That Burkitt's lymphoma is again divided into endemic and sporadic. Endemic, most common worldwide, it's endemic to Africa. Sporadic form is present in India. Presentation: jaw lesions, lytic lesions of the bone, draining sinuses, diffuse swellings, then generalized abdominal distension due to intra-abdominal tumor. In India, intra-abdominal tumor, other examination you will find pass mass per abdominally, unexplained abdominal pain, intussusception with tumors as lead point, association with Epstein-Barr virus is present in endemic Burkitt's lymphoma, is not so common in sporadic Burkitt's lymphoma in India. T cell type variety. It is similar to acute lymphoblastic leukemia, presents as mediastinal mass. T cell type of lymphoma is similar to acute lymphocytic leukemia and is presents as mediastinal mass. It presents as mediastinal mass. St. Jude staging. What is the staging for T cell lymphoma in non-Hodgkin's lymphoma? So non-Hodgkin's lymphoma is again divided, is because it does not have Reed-Sternberg cells, so it's divided on the type where the lymphoblast is coming from. So B type, T type, and the third one was intermediate cell. B type is Burkitt's lymphoma and diffuse large B cell lymphoma. T type is lymphoblastic lymphoma and aplastic large cell lymphoma. So right now we are talking about T cell non-Hodgkin's lymphoma. So it is similar to what? Acute lymphoblastic leukemia and it presents as a mediastinal mass, and the staging used for that is St. Jude staging. There are 4 stages. The first 2 stages low risk and the last 2 stages are high risk. So stage 1 and 2 is low risk, stage 3 and 4 are high risk. Lymph node involvement. Stage 1 has only 1 lymph node involvement and after that all has multiple. So stage 1 has only 1 lymph node involvement. Other lesions, there are no lesions in stage 1. Stage 2 single resectable GI lesion. Stage 3 non-resectable GI lesion. Stage 4 non-resectable GI lesion plus bone marrow or CNS involvement. So very easy to remember staging. Stage 1, no, only 1 lymph node involved. Stage 2, lymph node plus 1 resectable GI lesion. Stage 3, lymph node plus 1 unresectable GI lesion. Stage 4, one lymph node plus non-resectable GI lesion plus CNS or bone marrow involvement. Treatment: malignant chemotherapy. You give malignant chemotherapy. For low risk St. Jude staging of T cell lymphoma, you give cyclophosphamide, vincristine, prednisone and doxorubicin. You give cyclophosphamide, vincristine, prednisolone, doxorubicin, which is low risk, and then you give methotrexate if high risk. So malignant chemotherapy, you give cyclophosphamide, vincristine, prednisolone, doxorubicin, and if high risk it is you give methotrexate. Langerhans cells histiocytosis. Langerhans cells histiocytosis, also known as histiocytosis X. What is Langerhans cell histiocytosis also known as? It is known as histiocytosis X. Clonal proliferation of Langerhans like cell. There is a clonal proliferation of Langerhans like cell. Clinical feature: wide spectrum of disease, can be multisystemic. Lytic lesions in the skull. Sites involved: bone most commonly is involved. Wide spectrum of disease, can be multisystemic. Sites involved: most common is bone. Skull more common than jaw, like missing or loose teeth. Skull is more common than jaw. So clinical feature: there is a wide spectrum of disease, can be multisystemic. Lytic lesions in the scale. Langerhans cells histiocytosis. Predel cap is also a feature. There is a wide spectrum of the disease, can be multisystemic. There is a clonal proliferation of Langerhans-like cells. That's why it's called Langerhans histiocytosis. Bone is the most common involved site. Skull is more commonly involved than jaw. In jaw, you can see missing loose teeth. Skins, you can find scales plus discharge. You can find scales plus discharge. Skin also mimics seborrheic dermatitis and does not respond to the treatment of the same. Skin, it will resemble seborrheic dermatitis. You will treat it for some seborrheic dermatitis and it will not respond because it is actually Langerhans cell histiocytosis. Pituitary infiltration. Because of pituitary infiltration, stalk destruction, block in release of vasopressin and antidiuretic hormone, it can cause diabetes insipidus from posterior pituitary granules, MRI, loss of bright spot in posterior pituitary. So because of pituitary infiltration, the stalk is destroyed and so there is no release of vasopressin, antidiuretic hormone, and there could be diabetic insipidus from posterior pituitary granules, MRI, loss of bright spot in posterior pituitary. 4. Lymphadenopathy and hepatosplenomegaly. 4. Lymphadenopathy and hepatosplenomegaly. Now Langerhans cells histiocytosis clinical spectrum. Spectrum of Langerhans cell histiocytosis, age group and clinical features. So spectra of Langerhans cell histiocytosis. There are 3 spectra. First is eosinophilic granuloma. Eosinophilic granuloma. Second is Hand-Schüller-Christian disease. Hand-Schüller-Christian disease. Third is Lederer CV disease. Lederer CV disease, which is the severe form. What are the 3 spectra of Langerhans cells histiocytosis? First is eosinophilic granuloma. Second is Hand-Schüller-Christian disease. Third is Lederer CV disease, severe form. Age group, so they are becoming younger and younger in the more severe forms. So first, eosinophilic granuloma is older children, then Hand-Schüller-Christian disease is 2 to 6 years of age, and then Lederer CV disease severe form is less than 2 years of age. Classical features: eosinophilic granuloma, lytic bones in skull. Hand-Schüller-Christian disease 2 to 6 years old, skull defect, diabetes insipidus, exophthalmos. Lederer CV disease less than 2 years, severe form, seborrheic dermatitis, ear discharge, systemic involvement like hepatosplenomegaly, abnormal liver function test and lymphadenopathy, increasing severity going downwards and going in young children. Diagnosis: biopsy. On biopsy you will do immunohistochemistry. You will do immunohistochemistry and electron biopsy, and you will do electron biopsy. Tennis racket appearance in Langerhans his cell histiocytosis. You see tennis racket appearance, Burback granules, tennis racket appearance on histocytosis, immunohistochemistry, CD1A, CD27 Langerin, CD1A and CD207, which is also called Langerin. What are the CD markers? Immunohistochemistry, CD1A and CD207, CD1A and CD207. On biopsy for Langerhans cell histiocytosis. Treatment: simple lesion, curettage, intralesional steroids. Multiple lesion, vinblastine most common, 6 mercaptopurine and prednisolone. Third, refractory disease, cladribine. Refractory disease, cladribine. Simple lesion, you can do curettage and intralesional steroids. Second, multiple lesion, you can do vinblastine most common, 6 mercaptopurine and prednisolone. And third, refractory disease, you can do cladribine. Simple lesion, curettage, intralesional steroids. Multiple lesion, vinblastine most common, 6 mercaptopurine, prednisolone. Refractory disease, cladribine.